whether it's virtually or in person. My name is Holger Willenbring. I'm the Associate Director of the Liver Center. And we're very excited to have a seminar speaker today from Texas. So it's my pleasure to introduce Heather Stevenson-Lerner. She's at the University of Texas Medical Branch in Galveston, flew in from there last night, I suppose, as you said, via Oakland. So a little bit of a journey so far already. She's a professor of pathology in the Division of Surgical Pathology at UTMB. And she's also the director of transplantation and liver pathology. She got her training at UTMB also as an MD PhD, and also did residency in anatomic and clinical pathology. She then went on to do a fellowship at the University of Pittsburgh Medical Center, where she did a fellowship in transplantation and liver pathology, and then went back to UTMB, where she's currently pursuing her clinical interests in liver transplantation and gastrointestinal pathology, and her research interests are in the immunology of steatotic liver disease, with a particular focus on macrophages and their role in fibrogenesis. And we're very excited to have her present about this today, to learn about this today. I don't want to forget to say that one of our graduate students suggested Heather as a speaker, Simone Curiel, who saw her speaking at one of those AASLD single topic conferences and was very impressed. So we kind of jumped at that opportunity. And this also allows me maybe to point out to the trainees, to the technicians, students, postdocs, residents, and fellows in the room to please don't hesitate. If you have any suggestion for a speaker, just reach out to the Liver Center and we'll be happy to make it happen on your behalf, to bring in people that you're interested in hearing more from. So don't want to delay it any further, but we're very happy that you made the time to come out, and look forward to talking to you a little bit more today. Thank you very much.
Great. Thank you so much for the introduction. And thank you so much for inviting me. I'm from San Diego originally, so any time to come back to California is great. I'm actually going to get to go see my dad on the way home. So that's great. And I just to give you a little bit more of how I became interested in liver disease. My stepmother had Hep C growing up, so I was used to a family member with liver disease, and I was interested in it. I knew I wanted to study the liver early on, even in my med school essay. So I just was trying to figure out, how was I going to do that, and how was I going to be able to do all the things I loved. I love the clinical work, I love teaching and mentoring, but I love the research. The research really fuels my ideas and my passion, and really help for, as far as a physician scientist, trying to be able to do all of these things. And I really wanted to succeed at that. And I knew focusing on one thing, the liver, if I read liver to help patients, but then I also read a paper for liver and it helps my research and they overlap very closely, that would probably be my best way to be able to do all of these things. And pathology as well. I rotated in hepatology and infectious diseases. I even loved surgery, but just the flexibility in pathology and the in-depth look at the liver that you get to see every day, and just studying the disease pathogenesis just ended up being a really good fit. And actually done a lot of different types of liver disease, and hepatitis C and autoimmune. For my PhD, I studied ehrlichiosis, which caused a lot of liver injury and the fatal disease. And I isolated all the cells from the liver, NK and KT cells and all of that. And, I kind of felt when I did my fellowship in Pittsburgh, I was like, well, fatty liver disease, or steatotic now we're supposed to say. I wasn't sure. I was like, well, gosh, it's lifestyle. We can treat it with lifestyle and all of that. But then I ended up in Texas, and we have, I'll be showing you some of the statistics. We have a lot of steatotic liver disease and obesity in Texas. And I can tell you, I've been the only liver pathologist at UTMB since I became faculty in 2014. I read every liver biopsy unless I'm on vacation, and sometimes even when I am on vacation. And if you do a search through our Epic Beaker for steatosis and liver, I have signed out over 8,000 biopsies with steatotic, the word steatotic in them. And that's just about 10 years since I've been faculty. So we do still do quite a few liver biopsies, and I'm going to talk about some of the indications where we still do them. But I also want to emphasize all of the work I'm going to be showing you today is from archive material that is in storage, sitting in storage there. You know, what we give as a pathologist, we give you a diagnosis, maybe some inflammation and fibrosis, but there's so much more we can do with that material. And so that's what I'm going to try to show you today. And I really try to make this talk kind of something for everyone. I'm going to, I also had friends and family every week or two, oh, you study the liver? My doctor told me I have a steatotic liver or fatty liver. What do I do? So, you know, I had to learn about this disease. I had to learn about how we prevent it. And I really wanted to study it. I was seeing it every day. I was getting all these biopsies. So anyway, that's kind of what led to my project. And I'm going to be going through a lot of different parts of that today. And so this is the outline of my presentation. We can't go through it without mentioning the new terminology, which just came out last summer. A big consensus group came up with some newer terminology. I do have to say I like quite a few things about it, and I'll talk about that in a moment. But our names have changed. Steatotic liver disease now is kind of this umbrella term. We'll go over that. Talk a little bit about some of the grading and staging, which I'm sure many of you are familiar with. I'll talk a little bit about 2 patients in particular with very interesting laboratory values and liver biopsies, as well as looking at some more in-depth studies of their hepatic microenvironments. I'm definitely going to talk to you a little about the lifestyle modifications and things that we know that contribute to steatotic liver disease. And as I mentioned, I'm very interested in the macrophage response. And if you review the literature, there's tons of papers on macrophages in steatotic liver disease. And we do know that they're one of the main culprits. When they become pro-inflammatory and pro-fibrotic, they do cause a lot of the disease progression. And most of the clinical trials have focused on those cells. So we'll talk about that as well. And so here's what I was mentioning. So Texas, everything's bigger in Texas. So we have a lot of risk factors for Texas. We have a lot of obesity, we have a lot of diabetes, we have a large Hispanic population. But if you look at California, we're about 10% higher rates of obesity than you have here in California. I was so excited to see the lunch options. I'm like, oh my God, organic and something healthy. This is amazing. So in Texas, it would be pizza and barbecue. So you have to really try to eat healthier in Texas. You know, California, that's one thing I definitely miss is the healthy fast food options. I have 2 baseball boys. I wish sometimes after games I could get them something healthy, but definitely harder in Texas than here. And of course, we know this disease is increasing. It is, when I first became faculty, mostly I was reading like as a med student, resident, lots of Hep C, right? Hep C staging. And when we were getting the new DAAs, you had to have a certain stage to get trials and all of that, or to be able to get the drug. But now I see a lot more fatty liver disease, and we'll talk about why we're still getting those biopsies. But first, let's talk about the new terminology. And I'm sure many of you have heard of this, but there was a consensus group, 56 countries and like 70 co-authors and a lot of leaders in the field. Dr. Kleiner from the NIH, who helped with the NASH grading and staging, was involved. Cynthia Guy from Duke. So lots of people involved in this. And there was an agreement. So our steatotic liver disease, instead of saying fatty, which is kind of like maybe not the best term for patients to be describing the disease, and NAFLD is replaced with MASLD, which is metabolic dysfunction associated steatotic liver disease. Kind of a mouthful, but we'll talk about what that actually means. And then now NASH has been replaced with MASH. And I will say, you know, this is widely accepted, but if you look in this week's hepatology, Dr. Hoofnagel from NIDDK actually wrote a correspondence on this saying, I'm not sure, not everybody has metabolic. Couldn't it be nutrition associated? Then we could still call it NASH. So this is a consensus, but we're still trying to kind of make sure that we agree with a lot of these things, but I think it's better than where we were. And this is how this is broken down. I think the things that I think are better about the new terminology is on the far left, to call it MASLD. Basically, all you need is fat or steatosis in the liver and 1 metabolic cardiovascular criteria. And I'm going to talk about what those are in a second, but like things like hypertension and diabetes. So one of those risk factors, you can call it MASLD. The thing I like about this is, you know, we were so black and white with non-alcoholic and alcoholic. And let's face the fact, you know, there's a lot of people that have alcohol use that might not be, they're not completely non-alcoholic, right? So we need a way to think about the multiple factors. And I do think this does a better job at that. So we'll talk about that. So if you have metabolic dysfunction, which means basically insulin resistance leading to that fat in your liver, and alcohol, then we'll call it MET ALD, because that means you have metabolic and alcoholic contributions. Of course, we have pure alcoholic is, not quite as common. Of course, we have drug-induced causes like amiodarone, even steroids can cause fatty liver. And we have some, monogenic diseases. But if all of those, we cannot find a cause, those are the ones that we're now going to call cryptogenic. And remember, up till now, NASH or MASH has been the #1 cause of cryptogenic cirrhosis. Why? Because the liver enzymes are often very mildly elevated and it can be missed until it's later stage disease. We don't have serologies like we do for autoimmune PBC and all of those things, right? So that's why fatty liver disease or steatotic liver disease can be frequently missed in our patients. And what I really want us to do is, I want for primary care and everyone to know how to handle these patients. We've all seen patients with steatotic biopsies and imaging. What do we do? Who do we follow? Who is at risk NASH? And we really need to make sure these patients don't go missed and we end up seeing them when they're too late a stage of the disease to do something. And just to show you what does this mean, if we want to add the alcoholic component, how much alcohol is that? Or how much does that mean? Well, if you look here, here's the guidelines. And so if you notice on the left, they have 2 different numbers, and that's because females are more susceptible to alcohol-induced injury than men. So it's a little bit lower, but just to be considered alcohol component is about 2 glasses of wine on average per day for females and 3 to 4 for men. And if you have more than that, you start moving more towards the alcohol predominant on that little scale there. But just to kind of show you what it means in grams there for the different types of alcoholic beverages. And again, there are also evidence about binge drinking as well. That's why they give you the week, the average per week as well, not just the daily, but just to let you know what that actually means. So it doesn't take a whole lot to have alcohol as a contributor to your metabolic dysfunction associated disease. And so I wouldn't say this is really causes. It's probably more like modifications or factors that contribute, I would say, not necessarily causes, because it's very rare that one thing by itself leads to steatotic liver disease. It's multifactorial. And right, all of us are going to be exposed to certain things that might injure our liver. And we all really want a tolerogenic liver that knows how to respond, doesn't get overexcited, cause inflammation, fibrosis, and all these other things. That's what we would all want to have. So the more of these that we can control on our own, those are going to help us eliminate multiple hits here. So there's things you can control, of course, diet, your physical activity, amount of alcohol, gut microbiome. There's definitely some evidence about that. Of course, things like comorbid conditions we can control, like high cholesterol. Hypertension is actually one of these now too. Can't control our age over 50. I'll be 50 this year, so I'm not going to be able to control that one. Some of the genetic things as well. So what we are trying to do here, can't prevent all of them. Some we can. The ones we can control, try to control those and limit the multiple hits here to prevent this disease. So here are these cardiometabolic criteria. And to be honest, the new terminology uses these to make the diagnosis of MASLD. However, if you go and you look at the AASLD guidelines that came out for steatotic liver disease in 2023, even before this came out, they mention these risk factors. And I'm going to talk a little bit about the difference in primary care settings and in hepatology or subspecialty settings. But these are kind of helping us now. What they say in the consensus, these aren't really like to diagnose metabolic syndrome or to tell you that you're going to have a cardiovascular event, which is the main thing that people with this disease die from, by the way. This is really just to tell you that insulin resistance is the most likely cause of that patient's steatosis in the liver. That is what these are doing. But if you go back and you look at those guidelines, 2 or more of these risk factors should be considered kind of at risk and should be followed at least with a non-invasive test. And I will be talking more about that. So the things are obesity. Now it's just greater than 25, not 30, as we previously thought. Of course, anything pre-diabetes, diabetes, or treatment for diabetes. High blood pressure, and then high triglycerides or low HDL or lipid lowering treatment. All of those count. And I will tell you, since I've been looking at these and now I'm paying attention to these since last summer or so, I've really only had one biopsy that didn't have at least one of these factors. So most of the patients I'm seeing with liver biopsies meet the criteria for at least MASLD. And we'll talk what makes it MASH in a moment. So here's 2 patients. These are patients, we had a recent paper come out in JHEP reports, and I just selected 2 of the patients these are real patients that came in and had elevated liver enzymes. So you go in to your, primary care physician, and you have these elevated numbers. And patient one might not be quite as concerning as patient 2 on the right. There is still elevated transaminases. And if we use the normal ranges that are from our chemistry laboratory, which are there on the right, it doesn't look that bad. But one important point, and again, this is mentioned in the guidelines, that the normal range is actually lower than most reference ranges because the patients used for that reference range probably had undiagnosed steatotic liver disease. So the real normal for a female is down below 25 high and 33 for male. So if you really look at the norms we really want, these are higher than we would think they were, right? And you would definitely be concerned about patient 2. That's pretty high. I mean, we see that in steatohepatitis, but those are decently elevated transaminases. So now if we break these patients down and look at those cardiometabolic criteria, the patient on the left, I'm going to be talking about the biopsies in a second, but for the fibrosis staging, even with some of the non-invasive tests, F2 fibrosis or beyond is considered at risk NASH. So our patient on the left I'm going to show you in a second, had very little fibrosis, minimal fibrosis, but look at all of the risk factors, the metabolic criteria that this patient met. High BMI. As a matter of fact, that's why the biopsy was done. Inconclusive results on the fibroscan due to body habitus there. Had diabetes. That's one of the most important things to consider for at-risk patients. High triglycerides and on cholesterol medications. Denied alcohol. On the other side, patient 2 only had 2 of the risk factors. That was the patient with the higher numbers, though. Higher ALT, but less of these criteria, and then reported sometimes. As we know with our patients with their alcohol reporting, I think we need to be a little bit more, ask a little bit more details about what that means when they say sometimes, right? How many drinks a week, or what are you having? What are you drinking? Is it alcohol, liquor or wine? And that's important because it's really hard for me to say right here, is this a met ALD or is this just metabolic with that answer? And that's all we could find in the chart for this patient. And when are the biopsies still indicated? So, some people say that we don't need them as much, and I do agree because there's so many non-invasive things that we can do now. But for like these patients, it's when the results are indeterminate on some of your non-invasive tests, whether those are like the serum test for fibrosis or fibroscans and elastography. If there's diagnostic uncertainty, as we know, a lot of patients with steatotic liver disease have non-specifically elevated serologies for autoimmune hepatitis, for example. Like they also have elevated antimitochondrial, like PBC markers. And sometimes when they have higher numbers, the clinicians are wondering, hey, do they have fatty liver disease and something else, or that there's diagnostic uncertainty, or if patients have persistently elevated transaminases. And this is what I was talking about. I don't want to spend too much time on this, but I just want to make you aware of this. This is again from the AASLD guidelines, just mentioning that the way that we follow up on these patients is different in a primary care setting where we have a very low prevalence of the disease, or somebody who's sent to hepatology for elevated liver enzymes or known liver disease. So the tests you're going to do are different. Really what you're trying to do in a primary care setting is just exclude patients with advanced fibrosis. You don't want to miss those people that are walking around with, with at-risk NASH and you're not doing anything with them. So for example, like a FIB4, if it's less than 1.3 or if you want a high negative predictive value, basically. Once you find patients that you think are at risk or diabetics, moderate alcohol, first degree relative with cirrhosis due to NASH, things like that, those become more complicated. And that's when you may want to send them over to GI and hepatology. That's their job of managing these patients, right? If you have cirrhosis, you need to look for cancer, HCCs, you need to look for varices and all of those other things that you get when you get more complicated disease. So just a little bit different approach when we're looking at these patients. And this is really important because I'm going to show you some of the results from my research. We're trying to bring a lot of those patients, those 1,000 biopsies I had, we're identifying those patients that have at-risk NASH or had F2 fibrosis or ballooning and have a lot of these metabolic risk factors and bringing them back into clinic. Do we want to bring all 1,000 patients in? We're kind of targeting it based on these criteria and the things that we're finding that might be telling us the patients who are going to progress. And I think most of you know normal liver pathology, but just to show you, because it's quite striking when you see the patients with steatotic liver disease compared to these. So this is just, a nice liver with your portal tracts, intervening with your central veins. We don't see any macrovesicular steatosis, ballooning, inflammation. The portal tracts, usually your portal tracts will have a little bit of inflammation and then a little lymphocytic inflammation. We all have that, so that's normal. And of course, the main stain that we like to use in pathology for our amount of collagen or fibrosis is the Mason's trichrome. And just remember that portal tracts have collagen in them. And sometimes they'll be running through the liver, longitudinally, and you'll be cutting them in a cross section. You want to just make sure that you're not calling that a bridge, that we grade or stage the fibrosis correctly in these patients. And just to review, this is the activity scores, just because I'm giving you these numbers. So I just wanted to make sure everyone was aware of the activity. So when we say that, we're talking about the amount of steatosis, the amount of inflammation, and the amount of ballooning degeneration. So for me, for prominent ballooning degeneration, when I first put that slide on my microscope at low power, I can see it. I usually see like it's the big expanded hepatocytes, often with Mallory-Dank. And usually when you look at your trichrome, they'll have subsinusoidal fibrosis surrounding that. That is prominent ballooning. If I have to search around for it, but it's still there, that's a 1. And if I don't see it at all, of course, that's a 0. And then our fibrosis staging is pretty easy to remember. If you have periportal or perivenular subsinusoidal, one or the other, you get a 1. If you have both of them, you get a 2. Once you start connecting, you have a 3. And when you make bridges, and then cirrhosis is a 4. So I kind of like to think of like the early bridging, when we see the portal tract start to have those little kind of stellate or periportal fibrosis, if you think of that kind of as an arm reaching out of the portal tract, and then you go and you think about that happening at the central vein, because the ballooning in adults frequently happens around the central vein, it starts to reach out its hands, right, from the central vein. Once those arms are shaking hands, you got a bridge, right? So I am, my threshold for that, if I even see a very delicate bridge, if those hands are starting to shake each other, I will bump it up to like I'll call it delicate bridging. And I think that's really important, because sometimes people are really strict, I don't see ballooning, it's not steatohepatitis. Well, if I'm seeing fibrosis being laid down and it's starting to lead to bridging fibrosis, to me, that disease needs to be, the patient needs to be counseled. It's causing injury to that liver. And I think that's important. And so here are these 2 patients' biopsies. As I mentioned, the one on the left, inconclusive results with a non-invasive fibroscan. One on the right looks worse, like we thought. That ALT was much higher in this patient, but on the left was given a 3 out of 8, which we would, 4 or so is what we usually consider for steatohepatitis, and only a 1 out of 4 on fibrosis, just a very delicate amount of fibrosis. But again, if we looked at those cardiometabolic risk factors, that is kind of still an at-risk patient. On the right side, you can see much more macrovesicular steatosis. There was ballooning degeneration. The trichrome is a little bit light. I called it a 2-3 because it was just starting to shake hands, just starting on the reticulin. You could see nodules forming though. So definitely was a 2+ to me. And here on the right is just a really important picture for me. My mentor from Pittsburgh, Dr. Demetrius, taught me about these macrophages, and I had seen them as a resident in pathology, and I started noticing a lot in my fellowship. Those macrophages are always in areas of ballooning degeneration. They're always with this young, newly laid collagen. I knew they were up to no good. I wanted to know what they were doing. I wanted to know their phenotype. I didn't want to just call them pigment macrophages anymore. I wanted to know what those were doing, and I saw them, and we know that these are very frequently seen when there's liver injury. It's kind of evidence that injury happened there, right? But what else are they doing? Why are they so entangled in areas of fibrosis and subsinusoidal fibrosis? And really just seeing that in the microscope is what really sparked all of my R01 work. So just observations like that, that's why I think pathology is so cool. Sometimes you just want to figure out more than what you're seeing by light microscopy. And so we know now that macrophages are extremely important in the liver microenvironment. So we all, as I mentioned, we all really want this tolerogenic liver. Most patients, if we didn't have tolerogenic livers, all of the antigens that go through our gut every day through the portal vein would be activating our livers, and we would all have cirrhosis, right? So we really need a way to keep that tolerogenicity. And of course, our liver sinusoidal endothelial cells are extremely important, these guys here. And remember, your macrophages, the Kupffer cells, are going to be on the outside of that endothelial cell. So really, those are the first players that breach that tolerogenicity, right? Whatever they're picking up, if it's the wrong things, if it's pro-inflammatory things, those are going to get activated, and that tolerance gets breached. Once that tolerance gets breached, then you start recruiting in your circulating monocytes, these systemic bone marrow-derived macrophages into the liver. And I have some markers up here that are going to be important later in my talk. But those get recruited in, and they cause this inflammatory profibrotic cascade. They cause the stellate cell activation to become a myofibroblast, and then your collagen starts to be laid down. And so there's several markers here that I'm going to be talking about, but some of the important ones on macrophages, CD14, for example, by flow cytometry, known to be pro-inflammatory, CD16, known to be more anti-inflammatory, have both of them. Those are kind of an intermediate phenotype. We know that this MAC387 is one of the best antibodies. It's Mark's S100A9, very nice clean stain because it's nuclear. And then we also decided to throw in some of these targets of clinical trials, which I'm going to go over in a second. We know that these macrophages come in with a CCR2, CCR5 mechanism, and also galectin-3 is very important in activating the myofibroblast. So we added those. And then, of course, CD163 is also very important. There was some controversy now, I can tell you, during my fellowship, we weren't sure. We thought CD68s and CD163s were similar. Well, it's definitely not the case. They're definitely different phenotypes in the liver. They're not all one and the same. But I'm going to show you some of these, and these are the antibodies that we looked at. If you're more interested in learning about the techniques, a little more details, there was a lot involved in this as far as, training the algorithms and how we analyze the data, the antibodies and the clones we used, and the order you put them in for the multiplex staining. This manuscript goes into detail about the technical aspects. If you're interested, just wanted to share that with you as our first one that showed some of the data for this. And we focused on the ones that we found to be the most significant in the literature, but also some key macrophage markers. And we just wanted to look and prove that we could do this in different types of liver disease. And so you can see on the left is the multiplex staining with these markers below. And then we use Visiopharm software to separate the portal tract regions and the lobular regions so we can measure the different phenotypes in the different compartments. And then we looked at the different cells. So Visiopharm is really cool because just like flow cytometry, but if I was homogenizing this liver, I could tell you the cells that were there, but I couldn't tell you where they were. I couldn't tell you if they were in the portal tract. I couldn't tell you who they were next to or neighbor analysis. I couldn't tell you their spatial context. And that's the nice thing about keeping the architecture intact. Also remember, the cells we're studying in my lab, today I'm focusing on macrophages, but also L6, they don't like to be pulled out of their microenvironment. You pull them out. How do we differentiate macrophage? We pull them out and put them on plastic, right? They adhere to plastic. So they change their phenotypes. And if we're trying to understand these different phenotypes to treat them in patients, in my mind, we want to look at them in situ, how they're naturally expressing these markers, and not particularly L6. I mean, they completely change and lose their shape and everything if you pull them out. So anyway, I just think in situ is really important. And if you look at a lot of the tumor microenvironment studies, that's where I got a lot of these ideas from MD Anderson. They keep the spatial context for a lot of the tumor microenvironment studies as well. But what I would like to point out with you here is I'm just showing you 4 different common types of medical liver disease. On the top, you have a control patient. When we say controls, those are people I looked in the microscope and I'm like, why did they do this biopsy? It looks normal. And then I go and I look at their labs and they're normal. So I call those controls. And then we have hepatitis C, steatotic or NASH, and then autoimmune hepatitis. And then we do a Tisney plot. And what a Tisney plot does, it's basically a way to kind of look at how alike the cells are. So you can see that these patients, or the complexity of the phenotypes, you can see controls have just a couple different phenotypes, nice and tightly clustered. But as soon as you introduce any type of, either a virus or inflammation or immune-mediated disease, the complexity and the number of phenotypes increases. And now we're studying autoimmune hepatitis because look at this. I mean, everyone is focusing on macrophages and steatotic liver disease. Look at autoimmune hepatitis. So I'm really excited to speak with some of you today that work on autoimmune hepatitis because we have a lot of really cool things going on. Look at how many more. I think it's, just because it's not quite as common, but definitely important as well in immune-mediated liver disease. And then the cool thing is the reason you won't hear me using the terms M1 and M2 very frequently is because it's actually M1. I mean, this is with 5 markers and I have 30 phenotypes. So who's M1, who's M2? This isn't functional necessarily. To me, it's like M1 to M30, right? So I'm more of a pro-inflammatory, anti-inflammatory person just because there are so many phenotypes in these patients. And you can see here, like in autoimmune, there's some really hot phenotypes here. One thing we do see that CD14 is often higher in the controls, and it's because it's expressed on L6. And when they lose their tolerogenicity, they lose 14. So in this case, when you're seeing it go down with disease, it's because it's the L6 expression. But anyway, this little map is kind of neat because it lets you look at all these phenotypes and how much of that phenotype there is. And you can also go back and look and say, oh, those were in the portal tracts, those were in the lobules. So just to summarize so far, what I mentioned, lifestyle modifications are the most effective treatment for steatotic liver disease. As I told you, we all know if you go the wrong path, you can get cirrhosis and HCC. But don't forget these patients are also at risk for cardiovascular events and cardiovascular disease. So we really all want to have, the proper diet. Coffee actually is protective, exercise and vegetables, fiber, all of those things, and try to avoid the things on the bottom as much as possible. So this is the Mediterranean diet there on your left, and then what our diet is frequently in the United States. Sometimes I go when I'm walking through like the grocery store, I can't help myself but notice what's in people's carts sometimes, and I'm like, oh my gosh. So it's so obvious, right? Fresh things, fruits and vegetables, things that are, pure things, as opposed to things on the right where you read it and the ingredient list is this long. Probably not the best idea. And also your high fructose corn syrup, which is in everything. And you will not find it in my house. I have a 9-year-old and 11-year-old boys, so sometimes I can't avoid it, but I try to limit it as much as possible. So the other interesting thing about Mediterranean diet is it's not only good for steatotic liver disease prevention, depression, cognitive impairment. My friend Mary Claire Haver, an OBGYN from Galveston, wrote this book, Menopause. The right diet helps you with hot flashes and menopause symptoms. So it's really good for a lot of things, your heart, your liver, your brain, you name it. So try to be on the left whenever you can. And just one more thing on the high fructose. These are all the things that now we have evidence and data showing what it does. Other countries, even Mexican Coke doesn't have high fructose corn syrup. So the Coca-Cola in Mexico is higher quality than ours. If you're gonna have one, maybe you should have the one with pure cane sugar and not this processed sugar. So it's 240 calories, and those that provide these empty calories. And so kids are eating like their normal diet plus 2 or 3 sodas, and you're ending up with way more excessive calories. And that is one of the contributors to obesity that's thought to be childhood obesity. And also the gut microbiome. There's so many studies on this right now. You'll have some people that say, oh, those probiotics don't make it to the gut. And then you have the other group that are saying, well, actually they do. And I will tell you that the data is kind of all over the place. If you look in different countries, you'll see different organisms that are protective. Even different households will share the similar microbiomes with each other. And but I will tell you from what my overall picture is, the more biodiversity that you have, that is protective. So you don't want to have like a few pathogenic bacterial species. There's a lot done in this in alcohol as well, alcoholic liver disease. So definitely more on this. We do have a paper submitted to Microbiome with MD Anderson, where we looked at patients with Hispanics with steatotic liver disease in Texas, and we took fecal samples from these patients, and the one that had less liver disease, we identified the bacterial organisms, the good ones, and inoculated them into mice. And it did protect from steatohepatitis. So there is evidence that these organisms are able to pass orally into the gut and decrease the inflammation in the liver. So hopefully it's just been submitted, so hopefully that will be accepted soon. And then, of course, just to touch on some of these other drugs, I think the most important one that we should touch on here, you definitely want to control all these other comorbid conditions, triglycerides, cholesterol, hypertension, diabetes, whenever possible. But I will tell you, there's many times I get these livers and I see steatotic liver disease, and not one of these lab tests has been ordered. No hemoglobin A1C, no triglycerides, so if we have patients that we think might have some of these risk factors, we should definitely test for them, because we're not going to be able to calculate them if we don't have them available in the labs. But I think, of course, Ozempic is the one that everyone has been hearing about in the news. We've had it diabetic patients that have had great success with it can't get it. There's low supplies of it. And there's patients, that are getting some symptoms like gastroparesis from these, but they are causing, quite a bit of weight loss. And they're even now for diabetic NASH or MASH, and even non-diabetic some recent reports as well. So I think we're going to see more of those. But most important thing, if you watch any of the things from AASLD right now, people say lifestyle. These are never an alone. These are never the easy way out. We still need to counsel patients about all the other risk factors, lifestyle, all the other comorbidities. But this can maybe help a patient get more results quicker, right? They can lose weight. And when you lose weight, you're going to decrease the steatosis in the liver. And so here are the clinical trials that are targeting steatotic liver disease, and in particular macrophages. So this is really when I was at the liver meeting and I was looking at some of these results. A few years ago, I was there with Dr. Vierling, who's a good friend of mine and mentor, and we were watching some of these results, and they were jumping up and down because 20% of patients responded to this cenicriviroc, which inhibits these infiltrating macrophages into the liver. So they spent all the money on these trials. They were collecting baseline biopsies after year 1, biopsies after year 2, and they were excited after year 1 because about 20% of patients showed improvement. Well, what happened at the end of year 2? They didn't meet their endpoints, and the trial was terminated. Well, we know from all of our studies and my study that these infiltrating macrophages, they are bad. We see them there. They're in the liver, in mice, in humans. They are associated with disease progression. So why did this trial fail? And so my hypothesis from seeing these data was, I already knew from all of my data, some of the data I already showed you, patients are heterogeneous. Not everybody has the same macrophages in their livers. So why are you going to give everybody the same drug? Why are you going to treat everyone the same when maybe they have a different microenvironment? Not only that, let's say that, okay, we don't know because all they did was grade the NASH and the fibrosis. They didn't look, I wish I could have got my hands on those biopsies to do some of these other studies, but all they did was grade the activity in fibrosis. So we don't know if those patients that responded had those MAC387 CCR2 max or not. But I would predict if you gave a patient a drug for a year, maybe those macrophages aren't there anymore. So why would I want to give them the same drug after that first year, right? So maybe that's why they failed their year 2 endpoints. Maybe you already treated that phenotype. So anyway, those were our hypotheses that led to the next few slides I'm going to show you. Also would like to point out, so the CCR2, also the galectin has shown some good results. Of course, obeticholic acid, the FXRs agonists are ongoing. But this other one just came out. I have the paper here, just came out a couple of weeks ago in the New England Journal of Medicine, the Madrigal study with this thyroid beta-2 receptor agonist. That beta-2 receptor is more prevalent in the liver. And so this drug supposedly goes more to the liver than other sites. And they just published their studies and it looks very promising. And actually, one of their representatives is a UTMB alum. So I've been meeting with Madrigal a little bit to talk about maybe some of these studies as an option for some of our patients in our fatty liver disease clinic, steatotic liver disease clinic. So from this, we hypothesized that these patients may have variable macrophage phenotypes and druggable targets in the hepatic microenvironment. And maybe that's why these results were not as good as we had expected. And so this is the workflow. And I've had several people ask, there's so many other great spatial platforms. Well, I have a geomics in my lab. We have a 10X in my department. And I love these. We're doing several studies on the science and getting so much data from these platforms, but they're very expensive. They're complicated. They take quite a long time to learn. The data analysis can be challenging and tricky. It's not like you can just come in, hey, I want to use the geomics. It takes weeks of training. Not only that, it's expensive. And so what we're trying to do, I'm trying to get something that we can really bring to this liver biopsy material quickly, efficiently, and affordably for these patients that can predict their risk and maybe in the future their response to therapies. And so what we do is we take that archived tissue block, half of that liver biopsy unstained slides go to RNA extraction, and then the N-counter analysis. And then the other half is for the spectral imaging panels. And we do cut those biopsies fresh for the spectral imaging, just to let you know if air gets to those slides, the spectral imaging, you'll get a lot of autofluorescence. So but that's how our approach are these two platforms. Oh, and our two different panels, a macrophage panel, which I already showed you, and then this druggable target panel. And so here's just to show you, I just wanted to show you what kind of a control liver looks like on the left here. It's kind of a cold liver there. And then you can see when you have minimal fibrosis to steatotic liver disease or MASLD. And then when you have advanced fibrosis, you see a lot more orange. So a lot hotter liver in advanced fibrosis, which you would expect, right? More inflammation, more fibrosis, more activation of those inflammatory pathways. Pretty obvious there when you compare the minimal to advanced patients. And when we looked at these, now this is just completely, this is homogenized liver tissue. And interestingly, when we looked at these patients, each dot is an individual patient. We did not see a lot of differences in the macrophage phenotypes. Some patients, yes, some patients did have more CD68 in some of the macrophages. But if you looked at them on a whole, there was really not a whole lot of significant difference. Again, that CD14 goes down with disease, as I mentioned on the previous data and the previous paper. We see that over and over again. But what we did see was these chemokines and these druggable targets and ligands for a lot of those medications that are in clinical trials. CCR2, galectin, CCL2 were the most significantly upregulated genes in the patients with cirrhosis. And here I'm focusing, this is the pan-cancer immune panel from nCounter. And unfortunately, in hindsight, it did not include that S100A9 or MAC387, but I will be showing you that in the spectral imaging. I would suspect that one would be higher, and I'll show you some data to suggest that. But what I do want to point out here as well is the variability here in the patients with cirrhosis. So for example, if we're going to give somebody a CCR2 inhibitor, look at these two patients with advanced cirrhosis, the bottom two little dots. They don't look any different than a control group. So why, I mean, I can't prove, right? This is just association, but these two patients here don't even have a lot of CCR2 in their liver. Why would we give them a CCR2 inhibitor? And the same thing holds up for the galectin. These two patients here are really low compared to these up here. And same for all of the patients with cirrhosis. A lot of variability in those patients. And now we wanted to do to look at the spatial components here too, to see what they look like on an individual level. And that's where the spatial analysis comes in. So the way that we do this is we do these multiplex panels, and now we are using AI and machine learning and deep learning. But I will tell you that it is pathologist trained. So the AI helps you find, it's like the nuclear detection. But when it comes to a phenotype and an antibody staining properly, I'm the one saying, yes, that's a macrophage. Yes, that's, it is being trained. And then you're letting the program run more in an automated fashion. But we take multiple images from each patient's liver biopsy. At least 50% of that liver is collected in those images. So each little box there is a multi-component TIFF file that is downloaded and analyzed with Physiopharm software. And then the other thing we do is we take the numerical data, which comes out of Inform. It's called a cell seg file, and that's based on numerical data. So we analyze the data two different ways to make sure that it's robust and reproducible. So we have University of Michigan's computational biology department analyze the numerical data to look for these phenotypes. And then we use Physiopharm software in our own hands using the imaging, the multi-component TIFF files, just to make sure that we're getting the same results. And what we found was that MAC387, out of all of those phenotypes that we looked at, the only one that significantly increased with steatotic liver disease was that MAC387, the S100A9. All of these other phenotypes, there's some that decrease with advanced fibrosis. Why is that? And I'm not going to go into all this because it's just way too complicated. But the main reason here, we took all the individual patients, looked at all the phenotypes, look at the amount of heterogeneity of these phenotypes in every patient, even the controls. So again, the 14 goes down. Some of the MAC387 you can see right here. You can see hardly any of the controls had any of that phenotype, and it definitely goes up in the patients with steatotic liver disease. But I mean, there's so much variability to be giving these patients all the same treatments for these macrophages, right? I mean, everybody is different, and we know that. There's too many things contributing to these differences in our microenvironment to focus on just one cell type. So then what we did with our friends in Michigan, so again, a lot of this I learned from the tumor microenvironment studies I've done with MD Anderson. But when we look at cells, right, so far I've shown you numbers, prevalence, how many are there, how many in the portal tract, how many in the lobule, more numbers. But then this is called a spatial or nearest neighbor. Who's talking to who's next to each other, who's closer, who's enriched or who's depleted. And these are some studies that we do with Michigan. They use R scripts. Like G-function analysis, they use MATLAB and Giotto. And so what they're doing is looking like how many of these cell types are increased. And again, that same macrophage phenotype increased relationship or enrichment in patients with advanced fibrosis compared to minimal fibrosis. And if you look, this is just comparing the entire group. A lot of the more red, the more enriched you are. And a lot of the advanced fibrosis patients, it was CD68s and a lot of those MAC387s. So definitely not only increased in numbers, based on the data I showed you, but also enriched. They're connecting, they're talking to each other, they're near each other. And those are important in the patients with advanced disease. And again, this is just how you look at the individual patients with Giotto. And this is kind of busy, but the idea is every dot is a different phenotype. And when it loops back on each other in red, it's enrichment. And when it's a blue line, it's depletion. So every time you see a circle, that phenotype is enriching with itself. So the more circles you have, the more enrichment of phenotypes you have. And let me just go a little closer so you can appreciate that in one of these patients. So what we found was when you had advanced disease, you had a lot more enrichment of these phenotypes. This patient here had an extremely inflamed liver, and you can see that there's a lot of enrichment here. And what we found was some of these patients with minimal fibrosis, they looked like minimal fibrosis when I saw them in the microscope, but they had enrichments like patients with advanced disease. So then we followed up on these patients because, again, these are archive material. I have time to look at their outcomes. Several of the patients with more enrichments of that MAC87 ended up developing portal hypertension later on. So could we use this to predict people that are going to progress in addition to the things I already showed you? I think there's definitely evidence for that we could maybe try to see, hey, you look minimal right now, but you might be going this way. And I think that some of these tools will be useful. And then this is using VisioPharm. This is our multispectral imaging, looking at the markers shown below. The colors correlate here. And I don't know what happened to my little boxes, but here's our patient 1, that 3 out of 8. And our patient 2 with that 6 out of 8. And what we're doing is using tissue segmentation to separate the portal tracts from the lobular regions to look at these different phenotypes in these different patients. So we have controls, and then we have a really inflamed liver over here, a really, really active with an 8 out of 8. And so I'm just showing you some representative pictures. But remember, from each patient, we're collecting almost the whole liver to get these data. And so now we're looking at the percent positivity. So I'm showing you on the left, we looked in the portal tract areas. So on your y-axis, you have here's CD163, which is some people will call M2, but more of a anti-inflammatory wound healing type. We have our CCR2 and then our galectin, as well as the MAC387. So here's patient 1 out of 4 fibrosis, biopsy didn't look too bad, had a lot of those cardiometabolic risk factors, doesn't have a lot of CD163, but look how much CCR2 and galectin compared to the other patients. And I think what we need to really understand too is, do we want to look in the portal tracts, or do we need to look at the liver, as a whole? Where do we need to look at these targets? I mean, we know that a lot of the macrophages that come in are in the portal tracts, but I think that's still to be determined. But if you look on the bottom, we took controls here on the far left, and then we went across all the way from 0 out of 8 all the way to 8 out of 8 on our NAFLD activity scores, and went all the way across. And you can see that there's the heterogeneity is not always dependent on the amount of inflammation. However, when we compared the whole liver, that means the portal tracts and the lobules, the patient expression was a little bit more similar here. So this patient was really hot in the portal tracts. So when you do that, you do get a positive correlation with fibrosis stage and NAFLD activity scores as you increase. There is a positive correlation, and I think I've showed you that as well in the previous data. So just to review again, just to remind you, that patient 1 was the one with the low fibrosis, but a lot of risk factors. Patient 2 was already an at-risk NASH, but maybe didn't have as many markers as a patient you thought would have a more quiet liver. And so here are some other, I don't have time to go through all the data from these, but these are from my collaborations with Dr. Laura Beretta at MD Anderson. I first met her, I read her mouse models of NASH, and then we ended up becoming co-Is on each of our R01s, and have done a lot of really great, it's been a great collaboration. On that top paper, she goes in a little bit more on the details of looking what gets you from an F3 to an F4, also identified some interesting genes that might be able to predict risk. We are also adding those to our panels when we bring our patients back. And also just to highlight that gut-liver axis, if you inhibit TLR4 alone, you can decrease steatohepatitis in the liver and even liver tumor just by inhibiting TLR4. So that lets you know how much LPS in that gut-liver axis is very involved in the hepatic microenvironment. We also looked at STAT3 and found that STAT3, increased expression of STAT3, can also predict risk in these patients. So we're kind of trying to take a combination of her studies and my studies and try to find what are the least genes and protein markers that we can have to bring these patients back in and look at the biopsies we already have collected to predict their risk and maybe how they might respond to treatment. And this was also a recent paper, just came out this week in hepatology. I don't know if anyone saw it, but it's a really nice paper using imaging mass cytometry. And I'm just, showing you this here. There's a lot more details and some beautiful figures, a lot of work in this paper. But my main point was that they're talking about how important the spatial context is. So they looked at the tumor, the non-tumor areas close to tumor and the tumor, and they found that there was not only heterogeneity in the different patients with cancer in the liver, but heterogeneity in each patient's liver. So like there was clusters of cells, like had you biopsied right there, you might have missed this big old cluster of cells. And they looked at myeloid derived suppressor cells and tumor associated macrophages and found out that they are really suppressing the protective T cell response. So it's a very interesting paper, the TAMs through TGF beta. And so also take an arginase 1 through the myeloid derived cells. So really pretty spatial paper, just really highlighting the importance of the spatial microenvironment. And you would not be able to see these things had you homogenize the liver. And so just to summarize, we went over the new nomenclature. We talked about some of the risk factors, macrophages, of course, and how they are called into the liver. And that we saw quite a bit of variability, but there was statistical differences, particularly in that MAC387 or monocyte-derived phenotype. And we did see a correlation with those druggable targets with activity scores and fibrosis stages. But I just think moving forward, I know that we're not going to be doing as many liver biopsies. Maybe we'll be moving to more, liquid biopsies and things we can do in the serum. But we really, really need to understand that liver microenvironment and what those key things are to really be able to make something in the blood that we can find, right? It's really hard with a needle in a haystack with these inflammatory diseases. These patients are so, so different. So I really think we need these studies of the microenvironment to be able to get to that point. So this is what I would hope for the future. A patient, when you do order a liver biopsy, instead of just giving you a diagnosis and an inflammatory activity score or a fibrosis stage, that material is precious. That patient went through an invasive procedure to get that material. And I could give you so much more information than just a diagnosis. And as a pathologist, I feel in the future, that's what we need to do. We need to embrace AI and this deep learning and these different platforms. Hope they become more readily available, more cost effective and easier to run in our laboratories so that I can actually give you more information. I can put this in my surge path report and we can learn from these data about these patients and more about this disease. So I have a lot of people to thank. Of course, my grant funding. I've been really fortunate. I received a K award that was my stepping stone to getting my first R01. I've had a couple of co-investigator R01s as well, like I mentioned with MD Anderson. And I have a lot of collaborators, a lot of people helping me, excellent scientists in the laboratory. Dr. Omar Saldariaga, he's now assistant professor. He's been working with me for over 7 years, started as a research scientist. We have the same birthday, but you really need, as a physician scientist, someone in the lab that can do the bench work, and he's done that. And then here's my boys, Jude and Ryder. So with that, I will wrap up and take any questions. Thank you so much.